Malik Desoy, Dr. Malik Desoy, cardiothoracic surgeon.
Dr.
Malik Desoy is a cardiothoracic surgeon.
Oh, Dr. Malik De Silva, cardiothoracic surgeon at National Hospital. So our next speaker actually is Dr. Gisa Fontos. Actually, he's the chief of interventionologists in Hungarian Institute of Cardiology, Budapest, Hungary. And his special interests actually are research in TAVR. And he actually is a known person to us. Few years ago, he came to Sri Lanka to perform our first aortic valve implant, percutaneous aortic valve implantations in Sri Lanka at National Hospital of Sri Lanka. Over to you, Gisa.
Yes, I'm here. Can you hear me?
Yes, we can.
And do you see the slides?
Yes.
Can you see my slides?
Yes.
Yes, we can.
Good. Okay, Dr. Mendes, thank you very much for your kind words. I still remember pretty well those cases we did together a couple of years ago. So being here with you is truly my pleasure and privilege. I wish I were able to join you in person this time as well. But unfortunately today, when we are in the middle of the fourth wave of the pandemic in Europe, it's just impossible. It would be just a dream to be with you in Sri Lanka. Although Shepalika introduced, I cannot go for the next slide. I try to stop sharing and start it again. Can you see it now? Can you see my presentation and can you hear my voice?
We can hear your voice and we can see your first slide.
Good, thank you. Yes. So most of you probably don't know me, although Shepalika had a short introduction, but I'd like to continue this introduction. So my name is Gisa Fontos. I'm the head of the interventional cardiology at the Göttingen National Cardiovascular Center. My country is here in the middle of Europe, the red one. It's a tiny, small country in the geographical midpoint of Europe. The size is almost 1.5 times bigger than your beautiful island, but our population is about the half of Sri Lanka. Here is my hospital I work for. And I'll try to go to the next slide. Yeah. So although Alan Kribbe has performed the very first TAVR procedures almost 20 years ago, the procedural numbers worldwide started to increase significantly around 10 years ago only. The first huge step towards the extensive adoption of the procedure was the first European consensus statement document, which was back in 2008. And it was the year when we could start the exciting journey of TAVR in our hospital as well. So then we got guidelines in 2012 and updated one in 2017. And these helped to define the place of TAVR in our daily practice. This year, exactly 2 months ago, came out the latest ESC guideline. It's very new, and I'd like to cover important messages of this guideline in the first part of my presentation. I don't want to spend a lot of time with echocardiographic criteria, although they are pretty obvious. There are some patients where the clinical and echocardiographic findings do not match. And there are also patients who are in the gray zone between significant and non-significant aortic stenosis. In these cases, by this guideline, we have a new thing, which is the cardiac CT calcium score, which helps to decide in those patients. And there is also an important role of a full hemodynamic evaluation that might help in making a proper decision. For Proving that, I'd like to show you two examples how the hemodynamic measurements could affect our strategy. We had two patients. First was a 70-year-old male patient with a huge BMI with some comorbidities, and the other was an old lady of 87 years with angina, effort dyspnea. It's a very tiny, small lady with COPD, atrial fibrillation, prior PCI in the medical history. Both had preserved ejection fraction, no motion abnormalities. Both had clinical calcified leaflets, and the gradient was very similar in both cases with a mean of 28 and 29. And by echo, the aortic valve area was calculated to a little bit less than 1 centimeter square. We went for hemodynamic assessment for both patients, and our pressure measurements showed practically the same thing that we had with the echo findings, with the main gradient of 30-something in case of both patients. But there was a huge difference in the cardiac index. For the male patient, it was almost 6 liters, and for the tiny old lady, it was a bit over 2 liters per minute. So after that, we made a calculation of aortic valve area in the cath lab, and for the male patient, it was a bit over 1 centimeter square, and for the old lady, was less than 0.4, so it was a really critical aortic stenosis. So we made a coronary angiography. The male patient has a critical proximal LAD disease. There was nothing to do with the old lady. So the diagnosis in case of the male patient was a significant coronary artery disease with a borderline aortic stenosis. For the old lady, it was a paradoxical low-flow, low-gradient aortic stenosis with a very small and hypertrophic ventricle. So for the male patient, we went for the PCI and watchful waiting, and we are still see the patient after every 6 months. For the old lady, we performed TAVR, and the patient just is free of symptoms since then. So let's go back to the recommendations of the ESC guidelines. It's critically important. So all the aortic valve intervention must be performed in heart valve centers with active interventional cardiology and cardiac surgical program on site, and a structured and collaborative heart team approach. This is a class 1 guideline. The choice between the surgical and transcatheter valve replacement must be based upon careful evaluation of clinical, anatomical, and procedural factors. And the heart team recommendation should be then discussed with the patient, who can make an informed treatment choice. So it means that we are pretty close to what you got with the PCI. So if a patient is refusing the surgical valve replacement, then we can or might go forward with a TAVR. But we have some recommendation which patient should receive transcatheter and which patient should get surgical valve replacement. So it's for the patients below 75 years and low risk for surgical valve replacement, low STS and Euroscore 2, the patient should receive surgical valve replacement. In case a patient is at least 75-year-old, and in those patients who are at high risk for surgery or unsuitable for surgery, then we have a class 1 indication for doing the TAVI. All the remaining patients, according to individual clinical, anatomical, and procedural characteristics, the heart team should decide locally which is the proper valve replacement therapy for that patient. I will show a bit deeper later on. Transfemoral TAVI should be considered in patients who are inoperable. Balloon valvuloplasty may only be considered as a bridge therapy to either surgery or a transcatheter aortic valve replacement. So from this chart, you can see the following. Those symptomatic aortic stenosis patients who are on the right, for whom the valve replacement is not likely to benefit because of comorbidities, frailty, they should receive only medical therapy and no valve replacement. Asymptomatic patients with a good ejection fraction, negative exercise test, without adverse prognosis should be controlled and reassessed every 6 months. All the rest of the patients should go to heart team evaluation. And based on the heart team evaluations, those patients who are above 75 or unsuitable or high risk surgery, not depending on the age of the patient, these patients should receive transcatheter aortic valve replacement. Patients below 75-year-old or those patients who are unsuitable for transfemoral TAVI, but they are operable, even if they are older than 75 years, then a surgical valve replacement is recommended. So let's see what are those clinical characteristics that might influence our choice of treatment modality. So low surgical risk, younger age, and active or suspected endocarditis clearly favors the surgical valve replacement. The higher surgical risk, older age, previous cardiac surgery, and severe frailty tends to the direction of doing TAVR for these patient populations. There are also anatomical and procedural factors that might influence our decisions. So when the TAVI is not feasible from transfemoral, then it favors the surgical valve replacement. The patient has a porcelain aorta, sequelae of chest radiation, and the likelihood of severe patient-prosthetic mismatch favors all the transcatheter aortic valve replacement. There are also some anatomical factors that favors the surgical valve replacement, like the bicuspid, the very small and very large annuli that are outside of the range of the transcatheter valve. There are some valve morphologies, and clearly if the patient has a thrombus in the aorta or the left ventricle, then for these patients, the surgery would be the ideal choice. So in the second part of my presentation, I will like to go through the most important imaging modalities and their role in the evaluation, the assessment of patients for TAVI. So all patients who are evaluated for TAVI must receive a complete and comprehensive echocardiography assessment. It includes the LVOT measurements, velocities, the aortic valve hemodynamics, aortic valve morphology. We have to be able to identify diffuse leaflets, and additionally we need to evaluate the LV and RV function, LV dimensions, and the concomitant other valve problems as well. Angiography nowadays is not mandatory before the valve replacement. Of course, we need to clear the coronaries. We have to check the coronaries, but nowadays good quality CT scan in most of the cases can exclude severe coronary disease. But in the beginning and in the previous years, we did a lot of angiographies before. Sometimes we did left ventricular injection, ventriculography. We made an injection to the aortic root, which like the annulus, the ascending aorta size, the sinuses, the coronaries. But these are, as I mentioned, not mandatory anymore. But what is critically important to have a good quality ECG-gated computer tomography. It is what we say equivalent to the anatomy we have to face with. So we have to make all the measurements of the aortic annulus, including the perimeter, area, and the diameter. We have to evaluate fully the access routes, including the critical dimensions, tortuosity, and calcification of the vessels, both the iliofemoral system and all the way up the aorta. And we need to have good quality 3D reconstructions to have a good plan and implantation strategy for our procedure. It's very important to have a good multiplanar reformatting, which helps us to make the proper measurements. For that, we need to manually adjust the nadirs of each leaflet to align it in the same place, same plane. From that image, we can identify the orthogonal major and minor diameters, and we can make our measurement on perimeter and area of the basal annular plane. We need to check the sinus of Valsalva and the coronary ostium, the height of the coronaries. For that, we should make an imaging projection for either double oblique or the stretch view of the aortic root, and from that we can measure the height of the coronaries on both the left and the right from the annular plane, the coronary takeoff, which is critically important for checking. And also we need to measure the diameter of the sinuses of Valsalva. For that, a double oblique axial slice is used. We check the widest portion of the sinuses in a way that we measure the distance from each commissure to the center of the opposite sinus. These measurements, the Valsalva, the sinus of Valsalva height, sinus of Valsalva diameter, and the coronary height are all critically important for assessing the individual risk of that patient for coronary occlusion. This might influence the implantation strategy, the selection of the valve size and the valve type as well. It can influence the decision. And of course, sometimes we need some additional strategies to prevent coronary occlusion. We can do a balloon testing. We can do coronary protection with wires. Even we can park a stent in the left main or the RCA if we feel that the patient is in danger. For the procedure planning, it's also important to have a measurement on the aortic angulation, where we measure the angle between the basal plane, which is that one, the horizontal plane in the standard coronal image. It's important because for most of the valves, if its angle is more than 70 degrees, then we need to be very careful and we need to plan the procedure very precisely, whether we can take that curve at this angle or not. It also can influence the strategy of access with the valve, or it can even influence the valve type we choose for these patients. We need to check very carefully the peripheral vessels. We need to have good 3D reconstructions. We need the stretch vessel view and the magnified axial views for the evaluation of the peripheral vessels and the access route. We need to consider always the subclavian, because it can happen that after checking the CT, we realize that it will not be possible to make it from the femoral. So it's better to have it in the beginning from all patients. For the subclavian, we check the same things, the minimum lumen diameters, the calcification, and the tortuosity. And of course, the presence of lima graft is also an important factor for planning the procedure from the subclavian access. From the direct aortic access, we need to consider that for the self-expanding valve, at least, we need to have at least 6 centimeters of free space above the basal annular plane to be able to open up the valve nicely. And we need to also check where is the calcium in the aortic valve, and we can either check which intercostal space the surgeon needs to open up for getting to the proper portion of the ascending aorta. In Sri Lanka and that part of the world, the bicuspid aortic valve is pretty common. The transthoracic echo usually identifies it, but the definitive diagnosis is generally performed with the CT assessment or the transesophageal echo. This is how we do it. In mid-systole, we identify the basal annular plane and slowly scroll up and down from the annulus. And this is how we can clearly identify that the patient has roughly between the leaflets or a congenital severe zero type bicuspid. It's very important to have a good localization and morphology of the cusp and the leaflets. We need to see the extent and distribution of calcium in the leaflets. It's very important. The location of the coronary arteries, the size and shape of the supraannular effective orifice area. And for the bicuspid aortic valves, we need some extra sizings to be able to precisely choose the valve we want to have. So we need to see the degree of calcification, the calcium density and location that can impede the TAVI frame during expansion. We need to see the location and the length of the raphe, how many leaflets are fused, does the raphe extend the full length of the commissure or not. So this is how we can assess whether the size of the valve we choose based on the annulus and accommodate a bit above the annulus as well. And also we need to do the same measurements with the stenosis of valsalva width and height for assessing and checking the coronary ostium. So in conclusion, it's very important to have a good patient evaluation before the TAVI procedure, and around 90% of the work is done before we scrub. So if we have a good evaluation, then we need where we might have difficulties during the procedure, and we need to have a plan B and plan C, and we will know if we get stuck at some point, how can we avoid and how can we overcome these difficulties. So we have to have a good plan, and we have to be flexible in decision making during the procedure. And of course, a meticulous technique is also a must for the TAVI procedures. Thank you very much for your kind attention.
Thank you very much, Dr. Giza, for the comprehensive talk. We will be in touch after the next talk for the discussion. So it is my